Great, thank you. I will not intervene. This is not going to be a session where we have questions through the chair, other than if we have any questions coming in from the audience, in which case, as we go through this session, if you kindly raise your hands, and I'll ask you to say who you are, where you're from, and state your question, and we'll get a microphone to you. So to get us going, I'd like to start first by asking the panel themselves to introduce themselves. So if we start on this side, please.
So Chris Welsh, Health Education England.
Anne Rainsbury, Regional Director for NHS England in London.
Peter Ellingworth.
Colin Barrow, former leader of Westminster Council.
Tim Spicer, I'm GP in Hammersmith, where I'm chair of that CCG, and I'm one of the medical directors for Shaping a Healthier Future.
Cheryl Cole, a Queen's nurse and advanced nurse practitioner and Wandsworth Community Wards at St George's.
Tom Coffey, I'm a GP in Wandsworth.
And I'm Councillor Jim Madden, and I'm a Cabinet Member for Adult Care Services and Health in Wandsworth, and I chair the Health and Wellbeing Board.
And I'm Phil Thompson from Unison, and I lead the London Health Unions organisation, which is part of the London NHS Partnership, Regional Social Partnership Forum.
I'm Dr Emma Witcher. I'm a psychiatrist and medical director of South West London and St George's Mental Health Trust.
I'm Narendra Kapoor. I'm a neuropsychologist at Charing Cross. I'm also a visiting professor of psychology at UCL.
Thank you.
I'm Paru Desai. I'm a consultant in ophthalmology and public health at Moorfields Eye Hospital.
Charles Alessi. I chair the National Association of Primary Care.
I'm Miles Scott, and I'm Chief Executive here at St George's.
I'm Ros Gibbon-Wilson. I'm a radiologist and medical director here at St George's.
And I'm Pedro Castro. I'm Interim Director of Strategy at King's College Hospital.
Thank you. And before we get going, if Miles, you'd like to make a few remarks, and thank you from everyone for hosting us today.
Yeah, well, I'd just like to welcome everybody to St George's, and particularly anybody who's come from north of the river. I hope the atmospheric pressure differential hasn't upset anybody coming across the river. But you're very welcome to St George's. This is clearly a very important piece of work, and we're very keen to see the work develop. And I think, if I may, I'd also like to emphasise that not just are you coming here to St George's, but you are also here in South West London, and I know there's quite a South West London feel to the discussions this afternoon, and I think that there are some features to South West London which are different to the rest of London, which I hope will be useful to you in your deliberation. So while I appreciate this is the London Health Commission, I hope that during the course of this afternoon you'll take the opportunity to understand what South West London might have to offer as an example to the whole of the city.
I think that's great guidance. Thank you very much, Miles. Well, for the next hour or thereabouts, I'd like us to think about how we can continue to improve the quality and integration of health. We've been through periods, and very successful periods, of centralisation, and we've had a more patchy success around localisation. And perhaps someone on the panel would like to start us off on this journey this afternoon about, so what more can we do to improve the quality and integration of services, but thinking and focusing on, so how do we improve in the process the health and well-being of Londoners? Would someone like to start us off?
Shall I start? So, one of the things that the Commission has been looking at is this theme that, given that Lord Darcy did his report in 2007, Healthcare for London, and it started to look at what progress has been made, and clearly has shone a light on all the work that's been done to centralise services, such as heart attack, trauma, stroke, and so on, but has seen less progress in the localisation of services. And one of the things it's looking at is what people see as the main barriers as to why that progress has been less pronounced. So, be interested in people's views.
Please, just take it.
Thank you. Let me just kick this off, because I think we're at a place where healthcare has changed quite dramatically even since Lord Darcy's report, and our thinking around health has changed dramatically. I think the achievements that have been celebrated in London are wholly appropriate. The changes to stroke, the elements of centralisation which took place were all very positive. What I don't think we did as well is actually quite understand that the system has changed over the years, and also that people have changed over the years, and people's expectation of healthcare has changed over the years. If I had to say that the 20th century was a century of evidence-based care, the 21st century is a century of personalisation. It is about the people themselves. And I think moving from us talking about patients to talking about people is the first step, because issues like a sense of place and the importance of local government, issues around the importance of the non-health determinants, and issues around ensuring that whatever plan we come up with is actually the plan of the person rather than the clinician who actually comes up with it, are fundamental if we're going to achieve what we need to in terms of getting the health services we need in London. I don't think we've done that yet, and I think we really need to do that, and I would suggest these are the next steps we need to take.
Okay, thank you.
It's always the GPs who speak the most, so thanks, Charles. And as another GP, when we talk about localisation, I would say probably one of the most localised kind of part of health service is general practice. And I think maybe with Ara's work at Healthcare for London, we looked at very much of the structure of general practice. We talked about polyclinics and polysystems, and that made some progress, but it didn't really resonate with most GPs and most members of the public. And I feel that we should probably focus more on kind of outcomes of general practice. Personally, as a GP, I don't think I offer as good a service as I'd like to. The access to my practice isn't as good as I want it to be. I think most GPs would echo that. I think we're part of the health services which is very popular and praised by patients, but we ourselves know that we're also broken. That the access to general practice in London isn't as good as we'd like it to be. And also we know that, in fact, you look at the studies, if you've got good access to your general practitioner, you have less use of A&E, you're admitted less, you attend less, and your patient outcomes are better. So we know that we've got a clear kind of reason why she would make part of the system which is popular but not working well better. And I suppose in the last few years, we've looked at quality standards for emergency departments, for maternity, for paediatrics. And we've only just started now, I think 2 years too late, looking at quality standards for general practice. It's the Cinderella service, it's the poor sister, which is also, I would say, under-resourced and with too little focus. When we look at all the reorganisations in North West London, South East London, everyone talks about, the saviour is going to be general practice. We're going to reconfigure hospitals and it's all going to move into the community. Look at the reality, the investment in general practice is going down. The proportion of funding that general practice gets in London is now less than it was 5 years ago. Yet we always talk about moving services into the community, but money is not following the patients. So I suppose what I would ask for a focus on, if you want localisation, is let's get some real standards for general practice, similar and as robust and as well financed as a hospital. Let's invest people as well as money into general practice, and I think then you really will be able to see the shifts in care. I would say in Wandsworth, I know A&E at St George's is very busy, but Wandsworth now has the lowest attendances at A&E in the country because we've tried to invest in general practice, but that doesn't echo itself around the rest of London. So my call would be localisation, use general practice as your building block, and let's develop quality standards for general practice and get money to follow the patients.
Do we have some agreement with that or some dissonance?
I'm preempting now.
Sorry.
For another comment afterwards.
Can I just support what John said and Charles? And I think we've got to be realistic and say that this is not something that is peculiar to the health service in the broadest sense. As a retired senior police officer, people's demands and expectations have totally changed. And it's the point Charles was making, it's the people who've changed and what they expect from the services that are provided for them, whether it is the police service or the health service or the fire service or whatever it is. They expect things to have changed and be far more instant. The days have gone when things could be deferred. They expect things to happen. As a local councillor, I know, and I'm sure Colin was the same when he was at Westminster. 20 years ago, you could get away with responding to somebody within 14 days, possibly. Now they expect a response in 45 minutes, and if they haven't had one, they want to know why. And people have changed, and I think we've got to take that on board.
I think your point about people changing is started in the earlier conversations is an important theme for us because people's expectations are what we've got to meet as well.
Indeed, yes.
And those individuals' expectations are formed by many things. do you want to come in, Miles, and Rosalind?
So I would just say, I think a couple of things. I think people have changed, and one of the things that they like to have is information. And I think that applies across primary and secondary healthcare as well. There's an awful lot of different bits of information in different places. And one of the ways in which we could really improve healthcare, both in the secondary centre and tertiary centre and in primary centre, is by joining up that information that we have. So there's some areas where we're beginning to do it. We're beginning to get access for secondary care into primary care systems, into community systems and back again. But it's still really quite a fragmented picture. And I think leading on from that is also the patient's access to information, because nowadays, in the days of Google and the internet, patients expect to be able to get instant access to information about themselves and their health care, as well as everything else that's going on in the world. So I think that getting that kind of underpinning data that empowers the patient, partly the question of GP attendances is around patients not quite knowing where they ought to go, and it seems to me that if you don't quite know where you ought to go and you're not very well, then the default position is to go to accident and emergency. And I agree Wandsworth's done quite a bit to try and educate patients and provide alternative systems, but I think there's much more to be done there, and part of that is about patients understanding their pathways and understanding what's available, and the people who are dealing with them having access to the information about the patient wherever the patient turns up.
Okay. Miles, you were going to make a remark?
Yes, I think I agree with most of what Charles and Tom were saying, and I think that I was struck by Tom's comment about standards and being explicit about standards. It seems to me that if you look at what's happened over the last few years, some very clear standards and expectations that you can describe in a way that is meaningful to the general public, let alone to clinicians, have been set out in terms of heart attack care, stroke care, and so on. And guess what? We've really transformed things. With localised care, if that's what we're going to call it, there's been much more of a case of let 1,000 flowers bloom. So people have been encouraged to do lots of different things. We've got more initiatives in Wandsworth alone than you can shake a stick at in terms of developing services in the community. Some have been very successful, some have been moderately successful, and some of which, frankly, we probably need to stop doing. And it seems to me that the flowers have bloomed, and now is the time, as Tom says, to start bringing that together into something that's much clearer about what are standards. I would probably go slightly further than Tom and say I think the standards need not to be just about general practice. Actually, yes. I think they should be about particular pathways and what we can expect in a more home-based, community-orientated service, but we need weight behind that. If we're going to have those standards, it needs to be clear where the authority for them comes from, so that they are taken forward. In terms of some of the things that have blocked the development, I completely sign up to Roz's comments about data and records in particular, and we have got to crack this, and it almost certainly is going to require some investment. It's pump priming, but it's going to require some investment, and certainly in our conversations around here and in Merton about the Better Care Fund, that's been one of the big issues that we've addressed. I think there is, as an integrated organisation, as an employer of a lot of community staff, I think there is, I would have to say there is still, I think, an issue about too many of our services, for too many of our services, moving to a 7-day-a-week provision is still a big leap, and I think we've got to deal with that. And then finally, I think there's a kind of tentativeness, actually, and again, I observe within this organisation, even where we've got community services, there's a tentativeness, particularly among some of the on the acute side, in terms of their understanding of what they can use in the community, whether it be in primary care or in our own community services. And I think one of my reflections on that is that, frankly, overcoming that is going to require time. And just telling people that a service is available in the community and they should just refer to it isn't enough. And there's been all this stuff in the media this weekend about safe levels of staffing and the new nice safe staffing guidance. And one of the things that talks about, the guideline, is making sure that you plan enough time in people's working day to be able to communicate, whether it's with colleagues or with patients or whatever. And I think that some of that's important because simply switching from one system to another system isn't going to work. We need some kind of double running, some kind of transition, and we need to pay attention to the transition.
We need to do that. Right, Colin, you're going to ask a question. And then we'll...
Yeah, I have a question. In any competition for resources, the ones who want the resources tend to speak up, and the ones who have the resources tend to remain quiet. And I wonder, to take Tom's point, whether it is absolutely accepted by everybody in the healthcare firmament that what he says about the effectiveness and cost effectiveness of primary care is true. Because if it is true, then a challenge we have in framing our recommendations is to plot how to extract money from the hospital end of the and move it, or create the incentives to, or whatever, but get it into your space. Not because I have any particular view about it. I'm just saying, if it is true medically that what you say is right, then how could we structure? Could I hear from the hospital end of the people about how we get the incentives aligned so that he can get something which you accept is better?
Charles, just before we come into there's a remark going to be made next to you there first. Shall I? Just before. Thanks.
Picking up on your last point, I think it goes back to whilst hospital or acute providers provide data on what they do in terms of their activity and increasingly on some of their outcomes, general practice also provides some data as well. But the wider community services with other professionals involved in delivering care closer to people's homes, we don't have regular data sources for those to actually monitor what the quality of that care or that service or its acceptability for patients. We just don't have it. So I think that's a challenge to get to provide the evidence base that you're talking about. I think I would also echo what's also been said earlier, but I would add another word into the glossary that we're compiling, which is consistency in our approach for commissioning the CAC, in that Moorfields provides care, acute care for and elective care for across London, north, south, east and west. And based on that experience is what our plea for consistency, for commissioning decisions for what should be provided in different localities. There's a huge commonality irrespective of where you live, but the difficulties are that if there is inconsistency, and there is a lot, that it just adds a huge amount of administrative bureaucracy in terms of providing that care and delivering it, but also confusion for patients. I'm using an awful lot of C's here. It's not intended, it just seems to be coming out that way. But that happens. And whilst we're trying to deliver care pathways, there's an obstacle in that lack of consistency in decision making, because for eye health care, if we want to work with our colleagues in the community, which would be optometrists, and there's a very well established framework of optometric practice and service delivery in the NHS, it's very difficult because patients who go to a community optometrist could be providing care or services for patients coming from a number of clinical commissioning groups, and each one of those might have ever such slightly variations in their individual requirements, which then makes it a nightmare to actually make sure that you've got a pathway from a provider linked out into the community, so that the patient doesn't have to keep trotting up to outpatient appointments or vice versa, or for referrals for emergencies, etc. So there's consistency in the approach for commissioning care and services, so that you can better facilitate integrated care even between primary and secondary care, never mind the leap of faith into integrating towards social care as well, which is clearly important for us if we're dealing with sight impaired people. But all of that really, I think, applies generally, so that in terms of the information, everybody knows what to expect, what the minimum requirements are from a sort of whatever is wrong with you or whatever is concerning or causing you worry about your health. You know what to expect. There's a certain going back to what our patients' expectations are, yes, they do expect information, but it's quite difficult for them to get, if I've got this complaint or that complaint or this condition, what should I expect from the NHS? Because the care pathways, maybe we're not communicating them adequately enough.
Okay, thank you. Charles and Emma, you were going to make some remarks.
A couple of comments and a response, really, because that's why I intervened, because it's a response. I would support disinvestment from the hospital system as a generality. Of course I would, because it's clear that there is resource which is misapplied here in terms of the whole of the health and social care service. But I would push back a little on what Tom said, insofar as there is an assumption that primary care in terms of general practice is the only solution. I don't accept that. I would suggest that general practice in itself has a business model which has remained largely unchanged since the 1950s, and that needs to change. I would suggest that primary care includes optometry, includes community pharmacists, by the way, which we completely forget, one of the most underutilized resources we have, that are just doing the wrong thing. Again, misapplication is what we're talking about. And we're forgetting, I would suggest, the most important part of this, and that's local government. Because I go back to local government, because I don't think we can solve this on our own, healthcare. I don't think the NHS can solve this without local government. Because local government is going to solve this better than we have managed to solve it ourselves, because we haven't succeeded in solving it. We have a system at the moment which measures the things that we measure because we can measure them. They're actually the wrong things. They're the things we think are important, but actually, I don't think they're the people think are important. And that's the fundamental problem. We use systems to pay ourselves on the basis of the things we think are important, but not on what the people think are important. And I would suggest that person-designed metrics is the way we need to move forward. Metrics around wellness of populations is the way we need to move forward, not counting widgets. Now, the widgets can be really important to me or you because they could mean a stroke or heart attack, an important widget, but it's still a widget. It's still part of something.
Charles, thank you. Let's come back in a moment to the point about people and the consistency and the coordination of the landscape and the extent, and particularly bringing in local authority. Emma, you've been very patient there.
Well, I wanted to talk about what mental health can offer. I think I want to reflect some of the comments that Tom made, that actually mental health, the funding for mental health is minimal compared to the morbidity in the wider community and the wider population of London. In mental health, we've done a lot of work of supporting people at home within the community, within our crisis services, and the trajectory has been that there have been a reduction in hospital care to really support people to recover in their homes and to live their lives in the way they want to live them. And we have also long experience with integration with the local authorities, and in mental health we're very clear we cannot deliver without our local authority colleagues. But I think I wanted to go back to Charles's point around person-centred care. We know that the people who we see in mental health services are the same people who are seen by local authorities, who are seen in A&E because they have multiple morbidities within their physical health care. And I think we need to really move the focus away from designing networks around disorders to designing around a person's need. And I think it goes back to that point around integrating primary care, mental health and acute services, really to look at the needs of some of our most complex, disadvantaged and challenged people in London who we can do things better for.
That's really interesting. Tim, you want to?
So I was just picking up on the consistency point, the sense that I recognise your frustrations. I work across 8 CCGs in North West London, and to get agreement about consistency on that kind of landscape is difficult. But I think the interesting thing is, what's the relationship between consistency and personalisation? If you're wanting to deliver somebody's goals, their goals, there has to be a consistent way that information can be shared through the system and responded to the system. It's all right saying you can have your personal plan. We've got no way of delivering it because that's different there and that's different there and that's different there. And we often see consistency and personalisation as something in opposition, but actually we probably all use the internet that's got consistent codes in order to make links with different pages. We use consistent ways of exchanging money through banks. There's a sense that if you want to have a personalised system, you have to have a thing that has consistency of how you transfer information and consistency of expectations. And I suppose that is something that we know that we can deliver because other bits of the system deliver, but at the moment we step away from saying that's something we need to do. And I feel that our system is a bit at the level that when the railways all use different gauges, and there's a sense that we actually have to say, in order to deliver the aspirations of separate it, rather than just having organisations and primary care and secondary care, mental health, we have to have something that says this is the gauge that we're going to work on, this is the standard that we're going to work on, and we will adopt that, and anybody who's contributing services to that will use that common code.
So some form of interoperability is going to be critical in the delivery of consistency. Professor Kapoor, you're going to make some remarks now.
Just raise a few little maybe specific issues that from my own perspective. I think that one of the things that has changed in the last 5-10 years in London is the ethnic diversity, and there is specific challenges associated with those individuals, how one does a proper diagnosis, assessment, treatment, and they often require specialist expertise, and whether one has centres of excellence which will have resources to deal with issues relating to the ethnic populations. I think in the last 10 years assistive technologies have mushroomed. And again, how one best uses assistive technology, mobile phone and other technologies to improve healthcare. The whole issue of long-term conditions with the ageing population, you have lots more people with Alzheimer's, strokes, etc. And long-term conditions will invariably involve community-based interventions. And I think that how one deals with those is quite important. As a psychologist, I think I would see the application of behavioural sciences as important for patient safety issues and lots of other issues, using insights from behavioural sciences. As you know, the Cabinet Office has got a behavioural insights team. Hearts County Council is going to set up a behavioural insights team. So using the advances in psychology to understand human behaviour and how one can use that to improve healthcare. And last but not least, I think the emphasis is on patients and patient care. One shouldn't forget staff well-being, and staff in distress or whistleblowers or what have you. I think the staff side of it is important.
Thank you. Rosalind, I think you were...
Yes, I just wanted to come back to some of the challenge around disinvesting in secondary care. I think one of the real anxieties, and we've seen it in the kind of planning process of trying to look at healthcare across southwest London, one of the real anxieties for secondary care is that the patients continue to turn up and they come through the doors, and the anxiety that is raised by the thought of less hospitals or less money with the same number of patients coming through. So I think one of the things that, or increased numbers of patients coming through, I think one of the things that we really need to focus on when we talk about disinvesting in hospitals is actually how you make sure that you've got safe networks of care planned outside the hospital that not only the people in secondary care accept and see and are comfortable with, but the patients as well and the public need to see that there is actually a safe system out there. And just to come back to the point about consistency, so one of the work streams that I was involved with in local planning was around children's care. And one of the pieces of work that we did, recognising that an absolutely key bit to either stopping children being admitted to hospital or to getting them out quickly, a key bit is the kind of community nursing teams. We surveyed the community nursing teams across the CCGs, previously PCTs, across southwest London. They're entirely different, by a several-fold factor in different areas. And therefore, yeah, I can see that touches a chord. But therefore, it's, you know, you've got such difference out there. You haven't really got, we've talked about standards for general practice, and somebody mentioned we needed standards for everything. You do need to understand, it's something about that advanced planning that says, what does the safety net look like? How will it work? How are people confident it functions? How is there a consistency across it? Before you mention the closing hospitals or disinvesting in hospitals or whatever it is, because otherwise you get this enormous kickback and people get very anxious about the concept of something being done to them and done to their health service.
Okay, well, Rosalind, thank you very much. Pedro, I'll come to you in a second. Phil's going to make a comment, I think. But the piece we're picking up here is that we've got an ethnically diverse population. It's not a one-size-fits-all in terms of requirements. That also taking people with the health service and local authorities through a change is critically important, because you can't shut something one day without informing them of, so what else is there and how do you manage that. If we could hear from Phil and then perhaps come over to Pedro.
Okay, thanks. I was one of those people that came over the river, but I did have my passport with me, which is stamped as I came through the tube.
You might not get back.
Well, that's true. It might be a one-way passport. Yeah. I'm very interested by the heading of the session, if you like, about the notion of quality and integration being connected, and one plus the other equals improvement. And I think that the opposite of integration is fragmentation, and that certainly one of the concerns that absolutely all of the organisations that represent staff in the NHS have had, not just in the NHS but around working in healthcare provision, is the potential damage to quality through fragmentation, through the plethora of new organisations and the disturbance to the commissioning system and so on. And I was interested as well that so many of the initial comments did talk about Healthcare for London, because I think from our point of view, one of the benefits of Healthcare for London was that it began to develop not just reports about how things might be different, but it actually started to act on the reports that were developed. So they weren't just, to use Ruth Carnell's phrase, sort of on the shelf gathering dust, that things were being done with them. And one of the frustrations of the sort of tearing up of Healthcare for London was that it wasn't finished, it wasn't even partway through really, and that some of the benefits of the integration that were being proposed there we didn't see the full benefit of. And I think one of the aspects of that is interesting is that one of the bedrocks upon which that was predicated was the concept of double running, that you can have some double running. If you're going to do new things, you need to not introduce stability in a system when you're doing it. And I think that's one of the lessons that we could learn for the future. And of course it has a financial implication, as has been said. One of the other comments I wanted to make, when people talking about people presenting at A&E because of their conception of GP or primary care, I think one of the employers that I deal with most regularly is the ambulance service, and the ambulance service say exactly the same thing, that people present, if you like, to the ambulance service in addition to A&E instead of using primary care, and there are some reasons for that. And one of the interesting things is that every time the ambulance service tries to run a campaign to tell people not to use the ambulance service when it doesn't need to, 999 calls go up. And the reason they go up is because people have the notion in their head that they have a number that's connected to an improved service, even if you're telling them not to use it under certain circumstances. So there's a question there about how you redirect people's thinking, I think. And I could be wrong about this, but my understanding of the railway gauge issue was that Isambard Kingdom built the best system, the Great Western, based on a gauge of 4 foot 8.5, which was the width of the Roman road. And it was actually more stable as a train than the rest of the system. But it had to go because you couldn't run his trains anywhere else apart from between London and Bristol. So there's a question, isn't there, about you can have the best gauge, which might be the best thing to do, but if it can't be integrated across the service, you end up using something that will work but isn't actually the best design. And I think one of the one of the issues about the fragmentation question is how you move staff across the system when you have to have change. Because it's absolutely critical, and we're now talking about big things like 7-day working as well, which we can talk about technocratically and we can talk about in commissioning terms, but we've got 140,000 members in London who are patients as well, potential. And to move people around and provide healthcare at the same time is the question I think that we face, and we've been grappling with it for a long time.
Because you're bringing in principles of engineering, which is relevant because that's about change and design and iterative design. And again, it comes back to behavioural sciences, because whether it's about the population as a whole or it's the health landscape and the employees within it. And Pedro, you wanted to make some remarks, and we'll come back to you.
So I mean, one of the differences between, say, heart attacks and strokes and primary community care was that we had, and we've talked about the standards, but we had a clear clinically led standard for those services that was relatively easier to develop in a less fragmented kind of environment in terms of commissioning and provision. So that made it happen. So the difference here, I think, to start off, I don't think we have a clearly agreed set of standards in terms of primary community care and mental health and social care as to what should they deliver to the local population, number one. From that, we don't have a clear at all, we haven't got a clear model to deliver those. There's consensus around in terms of the ability to deliver that clinical those clinical standards, but also that is economic. And what we have is probably about 10-15 years of multiple integrated care schemes that have different levels of success, but they haven't been able yet to deliver any sort of consensus in terms of the model that we want to pursue. Some of that is because they take time, because of the pure the barriers, right? The fragmentation, contracting barriers, data information, and just actually getting around the table and agreeing what we want to do. And also, I would echo the fact that we kind of lose patience with some of those, and we don't push them to scale enough to see whether they deliver. And we kind of constantly seek in the next kind of magic bullet that's going to save the system. So we've got a number of different schemes which individually haven't yet proven their worth. I don't think we have a coherent model overall across health, social care, and mental health. And those are kind of some of the fundamental barriers. I would disagree, and I wouldn't position this as a kind of primary or community versus acute in terms of funding. I think the acute hospitals are definitely very aligned in terms of incentives, in terms of getting activity out. I think most of the hospitals in South London have extremely busy A&Es, and they've been hurt both in terms of performance, but also in terms of finance because of that. And we are all, I think, actively engaged in trying to deliver these solutions in terms of integrated care. But I think we are way away from kind of figuring out what the model is that we want to pursue.
So a highly complex system that clearly isn't yet a template that fits over it. There probably isn't another industry that's as complex as health, yes, or as many customers.
Yeah, and we don't help ourselves, to be honest.
There is that dynamic, and thank you for that honesty. Anne, I think you're going to make a few remarks, and I'd like to bring Cheryl in after that.
I wanted to try and nudge us on to, so what do you do then? So just reflecting back that we've had this conversation about two potentially competing things. So a conversation about the need to standardise the delivery of healthcare. And it's been interesting about, and I do it myself, we've all talked about settings of care, probably in a language that most patients wouldn't. So most patients wouldn't know what tertiary, secondary, primary care is, interestingly. But so there's something about how do you standardise the operating model of the delivery of care at the same time where you're trying to personalise the experience of care. And that's quite a tension, it seems to me. And it'd be good to get, particularly when we're going down probably sooner than we think, with more predictive medicine and genetics and so on, care will become more and more personalised, but we know we need to standardise delivery. So it'd just be interesting to hear from people about what practically do we do about that, because historically we've tended to do one or the other. We've rarely done both.
Well, Sharon, I don't know if that is something you can come in on there.
I can build on that in terms of the person-centred care. Working within Wandsworth, I think integration is a process. We have community wards with integrated teams, providing both acute and chronic service. But I just think with de-investment from secondary care, we already have lots of complex patients out in the community. And I think, community nurses, we're the ones that they're delivering care, and we try to be person-centred. That is challenging, but I think it's a culture. So it's thinking how we could foster this culture of person-centred care, because it will take time. It's the language we use when we speak about patients, and I think what we try to do is work together with patients. We can give them information, but at times there's lots of other things that impact on person-centred care. But it is the beginning. In terms of standardising community nursing, I totally agree with Bru was saying that it's very hard to standardise because every borough does something differently, and measurable outcomes, we need to look at what we are measuring. In terms of community nurses, I think, we need more support. We have problems with staffing, so if there's going to be even a greater shift, we need to look at staffing levels, safety levels, and how are we training and developing staff to actually manage these more complex patients out in primary care.
Sharon, thank you very much. Chris, you were going to say something just ahead of Anne's comments.
A comment and a question for everybody. The comment is, as someone who's quite interested in the workforce, can we stop saying 7-day working and talk about 5-day working to provide a 7-day service? There are some subtle but important messages there. And my question is that we've been talking now for almost 45 minutes and we really haven't touched on the digital revolution. And I would be very interested to hear if anybody thinks there are any answers within the digital revolution that would be of benefit to improving care and integration. Because it seems to me, with our ethnic diversity, we have actually got one thing in common. Virtually everybody has a mobile phone. That mobile phone can store hundreds of hours of music, thousands of photographs, arrange for you to receive money or send money, and a whole host of other things. What it can't do at the moment is actually contain your personal medical record as a person and a patient, nor can you arrange your healthcare through it. So are we going to address that digital revolution? Because very soon patients will be saying, I've had my MRI scan, can you give it me?
Great challenge. So from Anne trying to get his go on another stage and Chris's challenge around digital. There's lots of people putting their hands up, so let's do something that's a bit more mechanistic and roll around the table. We're going to start with you, Miles.
Okay, I think what I was going to say to Chris's comment, so I think one of the things that would be really helpful for the Commission to highlight is the importance of infrastructure, both as an enabler and also as a constraint on what we might want to do. So a really important piece of infrastructure has got to be the IT infrastructure, particularly around the care records, more than the bean counting. The bean counting can take care of itself, but in terms of the care records, which I think does play to what Chris is talking about. And from the integrated care pathway work we've done within St George's, but working with Tom and colleagues in Wandsworth CCG, the big thing that's come out of that is that to make progress, we have to have a single record, and we have to have the infrastructure that enables people to use that. And that infrastructure is actually getting more flexible and cheaper all of the time. But I would also like to put in a plea that we don't overlook the importance of other kinds of infrastructure. And it seems to me that fixed costs drive a lot of people's behaviours around this, and where you've got opportunities to make big changes in infrastructure, that's actually a really important question for London, not just for one board to think through. So one of the things that we've grappled with in South West London is thinking about if there needs to be change in what our hospitals do, how can we take advantage of the fact that, frankly, some of our hospitals need massive investment to do anything? How can we take advantage of that to ensure that we design something really different that will actually support really different models of care? And whether that absolutely puts your ideal bit of infrastructure in your ideal place that you would draw if you had a blank sheet of paper is kind of irrelevant, because you don't have a blank sheet of paper. And by focusing on those bits of the infrastructure that are most in need of investment, committing that investment, but committing that investment on the basis of change. And I think that could be that could unlock a lot of this, and that could enable us to take our staff and, frankly, our patients in public with us.
Okay. Please listen to what Miles has said there and keep some thoughts in your head. We're going to move around. Charles?
Thank you. Really, in response to Anne, what we can do now, we can do something very quickly if there is a will to do it, and I haven't seen that there is a will to do this. First of all, with information, the information about my medical record is mine. I can't see it. Why can't I see it? There's absolutely no reason why I can't see it. That can happen tomorrow. We don't need primary legislation to change that. The medical record belongs to the Secretary of State. The Secretary of State may wish to actually allow me to see my medical record. It happens to be in a general practice, but the GP doesn't own it. The Secretary of State does. So that's the first thing. Secondly, the digital revolution. Yes, of course we need to adopt the digital revolution. We still use the business models of the 1950s. The sadness is there are no systems of payment to use the digital revolution. So if a hospital decides they wish to actually allow people to actually access services better, there isn't a methodology for paying them to do that, which is effective and consistent throughout the system. So there are some significant problems around the systems of payment we have, which are based upon activity rather than the person. So that's the first bit, information. Secondly, let's start to tell a story about what a new hospital can be like. We think of hospitals as the places where you get better once you're sick. There is a new type of hospital which exists in other parts of the world. It's called the Centre of Wellness. We have a terrible infrastructure in terms of primary care, in terms of estate. We could well have some redundant infrastructure in terms of hospitals. Those hospitals don't need to close. I would shut nothing. What I would do is actually utilize that resource and utilize that estate to provide centres of wellness for people to be able to actually get to improve their health and wellness from where they are. That's the second thing. And the third thing is allow areas who are really up to make change, and I know there are areas to make change because my members tell me they want to make change in certain areas, to actually achieve that change. I know it's going to be hard, and probably we're going to have to build a cordon sanitaire around there to keep all borders out. But some hospitals wish to make those changes, are in a financial situation which is perhaps better than others. Some primary care clinicians of whatever type wish to actually move away from their contractual processes. I think we should allow that. I haven't seen any evidence of that happening.
Okay, thank you, Charles. Pearl?
The digital technology is the best thing that has ever happened to people who have a sensory impairment. It is the single most effective enabling assistive technology to make sure that they are engaged at all ages in all their activities of daily living, from educational, social, and even in the workplace, without any of the associated stigma that are usually associated with aids to hearing or for visual aids. It amazes me that in the 21st century we still send patients who have sight impairment down to get an aid which consists of a magnifier, and if you're lucky it is back illuminated, when in fact patients tell me every week in clinic that just being able to use an electronic reader And I'm trying not to name brand names, but you know what they look like. They're a square, and you can read your books on those. And they tell me that's the best thing that's ever happened to them, because the three things that they need is contrast, magnification, and good lighting are there. You can customize those, and they don't have to rely on lists of books or libraries that just have things in large print or are audio assisted. So I'm talking about sight impaired people, but equally it applies to those with hearing impairments. And it doesn't have to be people who are severely impaired. There are lots of different grades of this which would keep people going in and engaged fully to the level that they wish to. So that's my plea for my own clinical area. But I think wider, we have a diverse population, and the digital media is almost like our universal medium for communication, as Anne has already indicated. And we could make much better use of that, rather than all of us making our information leaflets in loads of different languages, etc. Would it not be a good idea if we just pull together and get really good examples, not just the written one, but the equivalents of YouTube videos, etc., which go back to having proper standards, properly evidence-based, etc. They're a good source for patients to lean back on. I think the other thing in terms of delivering care, we do need to take the potential of electronic patient records, both for documenting the care that we provide, but also making sure that our patients have access to that, which has already been said very eloquently by Charles. There's no reason why they shouldn't have access. It's their record. We don't own it. We are just, we just have the privilege of being their custodians of that data. So I do think that's very important. But also, we've forgotten the other thing is that if you have information, it does empower you and it does enable you to make some decisions for yourself. And if you're not sure of how to make that decision, you can actually engage, in an informed way with the professionals who you're dealing with. And increasingly, population, we are all doing that in our daily lives, whether we're looking for a good builder or a plumber or whatever. Why can't we do that? I'm not saying it's a thing for healthcare, but in terms of how do you go about making the decision? Do you need to do this or do you need to do that? It is important. And finally, it's not just about delivering care and engaging patients and empowering them to make decisions and taking responsibility, but it's about us being able to provide evidence to them about what we're doing and how we're doing, and also research, because without good research, you cannot move forwards either in terms of shifting the boundaries.
It's a great caveat there. Thank you, Pearl. Can we carry on around this side, Professor?
So just on the digital revolution, just my brief comment is that the field of telemedicine has advanced a lot in recent years, and taking advantage of that and having Skype consultations and things like that is something which would be important to take advantage of that. Another thing is I think that a lot of patient care should be geared around patient safety issues. If patient safety is important, and all the issues relating to patient safety, and I think that should be at the core of some of our thinking.
Thank you, Emma.
I think for me there's a further step. How do we empower people to be full partners in their health, managing their health care? And I think with regards to digital technology, it's one thing just to access your medical records. The next step is actually to input your medical records. And there are projects where people can input their mood into their medical record, and you can look at how people's mood changes. And actually that gives full ownership and empowerment. So for me, there's the next step, which is not just access, it's actually owning and managing your records yourself. And in mental health, we do co-produce crisis plans and care plans that actually the individual owns as part of their care. I think that goes on to my next point, is how do we empower people to own their own health care? And we do a lot of work about keeping people healthy, but how do we support people when they're actually unwell? And some of the projects we've done in Wandsworth around empowering people and psychological therapies for people who have long-term chronic conditions, around self-management and improving that, have been very positive. The other thing is, how do we incorporate the wider community? And another project we've done in Wandsworth is working with local faith leaders to recognise mental health problems, to provide advice and to direct people to the appropriate resources. So I think we have a sort of a wider community, the individual and the wider community out there who can help us solve some of the problems we face.
Emma, thank you. And it was a good insight and a check for us, not just to think about accessing what exists today, but how going forward we can actually use a medical record and it can become a live part of the experience for Londoners. Okay, Phil, we're going to keep moving, and then I'm going to ask Anne to make a few more remarks and the panel to bring us to a close. But Phil?
Well, certainly, I think on the question of digital technology, I think there's a danger, isn't there, of a gap opening up between the users of the service and the providers of the service. And there is this story, isn't there, probably an urban myth about ward rounds now, that the most difficult job, perhaps it always has been is the junior doctor, because the consultant goes around, gives a diagnosis, and then the patient goes onto the iPhone and comes up and checks what they think, and then the poor junior comes after that and gets all the difficult questions that the patient's got on the... Now, if that's true, and there's a lot of people who tell me that it is, then that gap is a dangerous one, because it sort of unhinges how you provide healthcare. And you can't go back to a time when everything that everybody said who worked in the service was believed, I'm a doctor, trust me. But neither can you have a system where the service itself doesn't have a proper thought-out, integrated view as to how to provide the kind of information ranging from medical records to how you book appointments even. So I think it is a dangerous gap to let open up.
Yeah, I think, Professor Kapoor had mentioned behavioural sciences to us earlier on in this session, and and how we help both the staff in the broader health and public health service to cope with an increasingly challenging patient. It's an interesting dilemma. Councillor James.
Yes, just following on from Phil, I remember being here at the annual general meeting of the Trust, and the chairman was asked by a member of the audience to comment on a particular set of circumstances, which was that he'd been to his GP, the GP diagnosed something and then said, and if you don't believe me, go and look it up on Google, which the patient wasn't very impressed by that, but that is an aside. But following on from Charles's comment earlier on about the involvement of local authorities, and I think local authorities, and I speak from my own, we are very keen to get more involved, and I hope that Miles and Tom won't tell me that I'm wrong, but we think that in Wandsworth we have a very good working relationship between the secondary level and the primary level and the local authority, and it's something we take forward, and we're very keen to get involved with. And to give an example, we're very proud that our levels of delayed discharges in Wandsworth are the lowest anywhere in London, and that is significant because it allows the hospital to ensure that the bed blocking doesn't take place, and that's something where we're working very closely with the Trust to try and take that forward. And then the other point I'd like to make is Emma's point about working with the community, the faith groups, and it's not just, it's what I call the 3 Ds, which are dementia, depression and diabetes, and to ensure that the leaders of the faith groups, the leaders of the community groups are made aware of the potential time bomb that's ticking over London, and if we don't tackle some of these issues at an early stage. So it's sort of working with a level slightly below primary care, whatever is below primary, I'm not sure, but to try and develop some of those processes, the co-production with the faith groups, with the community groups who are out there.
Very, very interesting. I think, again, back here, I'll come to a question in a second then, thank you. The mention of research, and we ought to really capture that. Tom, if we can come to you, and then I'm going to come to a question from the audience.
So I want to make 2 comments, one about personalisation and one about the digital revolution. Personalisation, when we've already developed some GP standards which are in a draft form, and when we asked the patients what was important, access was the key thing, but it was two parts of access. Access on the same day I want to see someone when I'm ill, but for them what personalisation meant was continuity. What they wanted was to see the GP they had seen before, and the way we were able to do that in our standards was to let them book up to 4 weeks ahead. Because if you can book up to 4 weeks ahead, you say, do you know, I can wait for my diabetes review to see Dr. Smith because I trust Dr. Smith. And so for that, personalisation was about continuity of care and seeing the same person. And the standards we've developed so far do try to encapsulate, urgent access. And just take your challenge earlier about kind of, is it really cost effective? I work in A&E, so tomorrow morning I will work in A&E and I'll see someone who has a chest infection and it'll cost the NHS £57, and I'll see the same patient in the afternoon in my GP surgery, it'll cost them £19. And I'll see the same patient, I'll do the same thing. So there is a discrepancy. On the digital revolution, I would mention two little projects which kind of are happening at the moment. One, in fact, which Anne probably has now forgotten, that she kind of funded a few years ago, in an innovation fund. It was developed by the Hurley Group, which is a big GP kind of practice. And they've got this new IT system whereby you buy it as a practice. We've just bought it for our practice, and patients can use their iPhone. And on it, you can do your symptom checker, you can book your appointment, you can cancel an appointment, you can see your own GP record, and we reckon about 20% of patients will use that rather than coming to see me. And and to be honest, it's phenomenal. I mean, I haven't got an iPhone yet. I've got an old one. It almost made me get an iPhone to see my own GP. So that technology is there, but needs to be rolled out. The second thing is about using established IT systems. St George's, I think Miles knows this, has got a very good PathLinks EPR system. And we're going to have this kind of widened PAF system in South West London. The system for GP works so well. Personally, I think we should build on that system to say, how do we share patient records amongst the health community in South West London? We could use that network of pathology systems as a way for all healthcare professionals, mental health, general practice, and secondary care, so we can access patients' records, outpatient dates, letters from practices. So you can use that system already. So I think there are some IT solutions there that we just need to roll out, and I think general practice is very cost effective.
Thank you. I think we're clear on that now. Could I ask you to state who you are, please, and your question or your remark?
I'm Gail Finley. I'm actually on the next panel. I'm Director of Health Improvement at the Institute of Health and Human Development at University of East London. But I just really, as you were going around, was formulating in my mind some points that actually were then raised by two of your panel on this side, and that is the importance of integrating with not just social care in local authorities and local voluntary sector organisations who are dealing with people with health problems, but actually recognising that people with mental health problems, people with heart disease, people with diabetes, people with multiple morbidities who go round and round in and out of primary and secondary care are all members of communities, and particularly in disadvantaged communities, it's really important that in integrated care and integrated health systems include building communities, healthy communities, empowered communities, strong social, formal and informal networks within communities. Because unless you do that, we're never, how you can integrate care and health care services as tightly as you like, but we're still not going to see the health outcomes and the reduction of health inequalities that surely this is all about. So it's a comment rather than a question.
No, but it was very helpful nonetheless. Thank you. Anne, please.
A couple of reflections in terms of how it fits with other panels we've done, and then if I can for the last few minutes just lob another question in for people, a completely different one. So I think there's quite a lot of themes in terms of a resounding agreement about the what, but with other panels, the thing when we said about why haven't we been able to do it has been the enablers. So it's the infrastructure, it's the estate, it's the incentives, it's the workforce, it's are we maximising the digital revolution. And I think that's the sort of theme that the Commission needs to take back, because one of the big differences, if you're trying to look at what happened with Lord Darcy's first report, that was very much about the what. It did have a section in there about the how, but I think this panel and others that I've been part of have really honed that down in terms of, this is what would help. So, and I, particularly the digital revolution, we haven't actually reflected on that other industries have done this. So we probably all do banking, online. We probably, I'm not going to name, but we go shopping online. And actually, as consumers, we've taken quite a lot of the legwork from the system. And I think what's the equivalent of that in health terms. So my last question, just to get a quick reaction from people, is one of the questions that the Commission's been looking at is, at the other end of the spectrum, are there any other areas where we should consider centralisation of care, where the Commission should make recommendations that London should look, So is there another example of trauma or stroke that people think we haven't made enough progress on, and that they think that the Commission should shine a light on it? So last sort of 5 minutes.
Great. Last 5 minutes, please. Some quick fire responses to that.
I'd say, workforce planning, to be honest. I sense it's too disparate at the moment, and we're all trying to say, I need 4 extra GPs, 5 extra nurses. When it was Londonwide, I know it's not quite what you meant more about clinical speciality, but where I feel that it's become fragmented, I just do think that how we arrange and plan a workforce would be helpful if it was done.
And that is a theme Tom has come up in other.
Great, okay. Guys, you've got a couple of
so in terms of the service side of things, I think this is something where you can draw something from South West London. We spent a lot of time developing a lot of clinical consensus around some changes which have, for a whole host of reasons, gone in a slightly different direction. But within that, there was some clearly evidence-based proposals, particularly, I would say, in the area of children's services. These are frankly changes that are happening anyway, but because they're happening in an unplanned way, everybody's being left with the infrastructure and the fixed costs. And I think, our ability to fund some really exciting new models of children's care would be enabled, particularly by a different approach to what inpatient paediatrics really is and needs to be. I think you can make similar arguments around some aspects of emergency care still, particularly on the surgical side. If you think about the things that we've had so far, they tend to be quite medical, heart attacks, strokes, and so on. So on the surgical side, just in terms of Tom's point about workforce planning, I wouldn't disagree with that at all. I would, one slightly parochial point, but it is the London Health Commission. If there is to be more of a London orientation to education and workforce planning, it must take into account that the natural networks for workforce go well beyond the M25. And so, in South London, for example, there's as much to be said for bringing workforce considerations together across South West London, Kent, Surrey and Sussex as there is, frankly, between South West London or South London and north of the river.
Right. So,
2 areas. One is mental health. In London, we still have a choice. We can either get our mental health dealt with and our physical health ignored, or get our physical health dealt with and our mental health ignored. I think it's about time we started to think differently about mental health, and there could be some really big decisions associated with that in terms of structure. I'm not a person for structural reform, but inevitably those questions will arise. And the second issue is again about workforce. I am extremely disappointed that what I still see is workforce being determined by questions being asked of leagues associated with crafts, and the crafts giving opinion as to how many people they need. If you ask the craft of carpenters how many carpenters you need, they'll tell you plenty. And we're still producing plenty of carpenters, electricians and everything else in medical terms. I'm using an analogy. Instead of thinking about what people need. That is one of the biggest disappointments, and I think we need to fix that quickly.
That's to the workforce planning point.
And it's demand planning as well is coming through in there, which I think is quite important. Chris?
I was just going to follow on with the comment about that, because I come from the organisation that's tasked with workforce planning for healthcare and public health workforce. And the comment I was going to make is it is not medical workforce planning, it is the whole workforce planning. And just as the example that was used earlier, we ignore the high street pharmacist at our peril.
Yeah, and I think there was a remark we captured earlier. It was a very good one.
I just want to make an observation while we're on this topic. Workforce planning is a concept that sort of strikes fear into me as being a sort of centralised. Aren't patients inconvenient? They go to the wrong place, they call the wrong people, they call an ambulance. What a nuisance they are, aren't they? They look up their condition on the internet. They think they know more than we do. They demand what they want. In other words, they're behaving like we all behave when we're dealing with Vodafone. But the health service is astonishingly resistant to just following them and doing things the way they want them done, while at the same time cheering on that they are involved in their care, they're involved in their health, they're involved in their... You can't have it both ways. I think there are questions about disadvantaged groups and the people who can't do this, but there's a vast number of people who can, and I think it will be helpful if we let them.
Thank you.
I had two kind of slightly lateral. They're not centralised because I wouldn't answer the question, but one is the idea of having dedicated facilities for certain things like 23-hour surgical stays is something that is akin to how we centralise stroke. And I think that the idea that every hospital should provide everything actually doesn't benefit patient outcome. So the idea that you have dedicated facilities that actually do quite a limited range of activities that improve outcomes is a way of extending the centralisation concept. The other thing is that you could look London-wide and say there are some high-need groups that are actually quite low numbers of people. So complex learning disabilities across London is only a small number of thousand people. And you might not centralise their care, but you may centralise the coordination of care that would actually get better outcomes in a distributed way.
Thank you. Well, we're just coming to a close. I think. Sorry.
Just a couple of points. I think from specifically around some of the issues facing mental health, 136 provision around London. There is a piece of work that is going on around that, but this is the interface between the police and health services and people who are in a very distressed state, and how we manage that more effectively across London, I think, is an opportunity. I think the other thing is we have a lot of Londoners who may actually be sent out of area for particular parts of their care, and that's in partnership with local authorities. And how do we think about that across London to make sure our population get as much of their care in London as possible?
Just very quickly, I'm not sure I agree with Charles about the Guild of Carpenters, because traditionally those sorts of guilds actually didn't want to oversupply the workforce so they could keep wages up. Certainly true of guilds before unions, if you like. I mean, my daughter's going to qualify as a speech and language therapist, hopefully, in the summer, and I want there to be a job for her to go to. I don't want there to be twice as many SLTs as there are jobs. So that's actually not just a question of workforce planning, but are there the right number of jobs in the system? So it's balancing that, I think, in a way that makes sense for the system, for the providers of the system, and for the users of the system.
Okay, thank you. Professor Kapoor.
There was this decision then for trauma and stroke to be for specialised centres, and maybe there's a case for neurological rehabilitation to be looked at, and whether you could have specialised units for that.
Thank you. Well, to try and summarise this rich debate would probably take me the next hour, and I'm not sure I'm capable of that, or I have got another hour. However, what is clear is we started out today wanting to talk about and focus on Londoners, and thank you for doing that, and where it's appropriate, raising both the diversity of the population in London and the fact that sometimes it extends beyond the boundaries of London. Quite clearly, some form of demand planning, certainly the resources that we apply whether it's at a local authority level, it's public health, it's in social care, or it is within the extended NHS, is going to be very, very important. But from the Commission's perspective, thank you very much for your time and your insights and being as candid as you have been. Thank you.